Hello, my name is Selena Galilea Paginto, and I'm going to talk about neonatal mechanical ventilation using evidence-based concepts as a requirement for GNRS 5632 NNP2 at the University of Texas Medical Branch. Objectives for this presentation are to enumerate the goals in optimizing ventilator settings and treatment, understanding the basic parameters of conventional ventilation, enumerate the evidence-based concepts of mechanical ventilation, including the precepts, recognize the parameters that indicate when to start mechanical ventilation and what to assess post-mechanical ventilation, enumerate the guidelines for a protective approach to ventilator settings and treatment, and distinguish ventilator graphics affecting the infant on a mechanical ventilator. Goldsmith mentioned in 2017, to better appreciate the need for a systematic approach, consider that at last count we have identified 290 names of modes and 33 ventilators in the United States alone. As we focus our attention to how the ventilators are affecting the neonate, we also have to focus on the most important goal of protecting their lungs. The definition of terms and the details of mechanical ventilation we will discuss relating to significant work will be involved in achieving this primary goal. It is not an entirely mechanized or robotic function, but we should recognize that we are dealing with an individual life form. Its customized requirement is microscopic, and we must think of the very tiny but major components of the respiratory circuit, which is the alveoli. So when I hear PEEP or PIP, I question myself, how much of that PIP is reaching the neonatal lung? And rewarding that into the main concept and asking how much of that pressure reaches the alveoli. The significance of understanding neonatal lung mechanics. Neonatal lungs are fully compliant. They have very short time constants. That's why you put them on prone position and they will sat real good for some time, but then after a while they will start desaturating because they cannot tolerate it. Normally, they also have rapid respiratory rates and they have very short inspiratory times to match their lung mechanics. They have limited muscle strength and they have a very compliant chest wall that they struggle to develop adequate inspiratory flow and pressure. This situation imposes great technological challenges on device design, especially in terms of triggering ventilator inflations in synchrony with the onset of inspiratory effort, inflation termination, and tidal volume measurement. Suboptimal ventilator design for neonatal applications may lead to excessive trigger delay with asynchrony, or failure to trigger or terminate inflation, and errors in tidal volume measurement or delivery. These technological challenges have largely been overcome in modern ventilators but remain a problem in some older devices still in use. That's why it's important to have a clinical eye to be watchful on this neonatal lung mechanics. And watching ventilator graphics and the clinical skill will promote a protective lung approach. And also, in due time, as we see all these changes at the bedside, we will be able to manage the babies and provide the necessary treatment to prevent ventilator-induced lung injury. So why do we have to optimize ventilator settings and treatment? Optimizing PIP with the goal of providing a volume of 5 to 6 ml per kilo will enable the clinician to promote adequate lung expansion. This knowledge of having an adequate chest rise will prevent barophobia and will also prevent barotrauma. Optimizing PEP with the goal of preventing hypoventilation and overdistension will promote hysteresis, thereby preventing pipophobia and atelectotrauma. Optimizing inspiratory pressures with the goal of preventing excessive pressure and decreasing E time, and inadvertent PEEP will prevent ventilator-induced lung injury or valley. Optimizing synchrony with the goal of promoting patient comfort will in turn prevent misuse of sedation. And optimizing tidal volume with the goal of supporting functional residual capacity will help the neonatal lung recover and thereby promote uh, earlier weaning from mechanical ventilation. Regardless of the mode and method of support, the basic concepts of conventional positive pressure ventilation remains the same. The basic parameters of conventional positive pressure ventilation are peak inspiratory pressure, or the PIP, with an initial requirement for the neonates between 10 and 20 centimeters of water, inflates the alveoli. Positive end expiratory pressure, or PEP, prevents the alveoli from collapsing and keeping it open, preventing atelectatrauma. Ventilator rate, involving the components of the inspiratory and expiratory ratio, is the number of breaths per minute, with the time constant for exhalation being longer than the inhalation part. And then there's the FiO2, or the inspiratory fractional oxygen concentration, and the flow rate. Understanding the basic parameters or the components of mechanical ventilation will enable us to optimize the treatment. A PEEP level that is set too high or becomes too high when PEEP is not reduced as lung compliance improves will lead to overdistension of the lung, or incomplete exhalation with hypercarbia, increased pulmonary vascular resistance, and impairment of venous return with decreased cardiac output. Excessive PEEP will also suppress spontaneous ventilator efforts. Setting PEEP should be guided by a visual appreciation of a just adequate chest rise, including audible breath sounds and preferably the measured exhaled tidal volume, which should range between 4 and 6 ml per kilo, depending on the patient's size, age, and diagnosis. There is no optimal PIP for all infants, and the PEEP required to achieve adequate tidal volume is not based on the size of the infant. Very small infants may have poor lung compliance and transiently need quite high PIP. Peak pressure by itself is not injurious to the lungs without generating a correspondingly high tidal volume. Choice of the inflation time should be based on the time constant of the infant's respiratory system, on how quickly the gas gets in and gets out. Sometimes it is set at 0.4 to 0.5 seconds for term infants and 0.25 to 0.35 seconds for the preterm infant. Inspiratory time, or I time, should be long enough to allow completion of inspiratory flow before the ventilator cycles off, but should avoid a long inspiratory hold that increases patient ventilator asynchrony and the risk of air leak. Expiratory time is determined by direct setting or indirectly by preset ventilator rate. It is adjusted to achieve a sufficient level of support to reduce the work of breathing and produce adequate minute ventilation. The ventilator rate may be a minimum value with the actual rate determined by the infant, as in CMV or AC or PSV, or may directly determine the actual ventilator cycling, frequently, as in an apneic infant, or during IMV or SIMV. Repeating what Goldsmith said in 2017 about having 290 names of modes of ventilation and 33 ventilators alone in the US will enable us to appreciate the need for a systematic approach. It will also enable us to appreciate that there are more than 9,000 possible combinations to individualize for a successful treatment. How can that be possible? Understanding ventilator precepts and the common terms used for mechanical ventilation will enable us to grasp all these possible combinations. Let's start with a countdown. So, number 10, the mode classification. It is a classification of ventilator mode based on its control variable, breath or inflation sequence, and targeting schemes. Thus, the ventilator mode taxonomy has 4 hierarchical levels. The control variable, which is used for primary inflation, the breath or inflation sequence, the primary targeting scheme, and the secondary targeting scheme. So, the control variable is used on pressure or volume control for the primary inflation. The breath or inflation sequence are used for the CMV, the IMV, or the CSV mode, while the primary targeting scheme will be seen on CMV and CSV, and the secondary targeting scheme used for the intermittent mandatory ventilation. So, number 9, targeting schemes is a model of the relationship between operator inputs and ventilator outputs to achieve a specific ventilatory pattern, usually in the form of a feedback control system. Targets can be set for parameters during an inflation, within an inflation target, and there are 7 basic targeting schemes for mechanical ventilators, where 3 is being used in the neonatal population, namely a set point targeting scheme, servo targeting scheme, and adaptive targeting scheme. The set point. This is a targeting scheme in which the operator sets all the parameters of the pressure waveform or volume and flow waveforms for the volume control modes. The ventilator does not adjust any targets automatically. This is how the mode called time-cycled or pressure-limited works. The servo targeting scheme is a scheme in which the output of the ventilator automatically follows a varying input. Current examples for neonatal ventilation is the NAVA, or Neurally Adjusted Ventilator Assist. The adaptive scheme is a targeting scheme that allows ventilator to automatically set one target. Modes that use pressure control with adaptive targeting are often referred to in the literature as volume-targeted or volume guarantee modes. Number 8, ventilatory patterns. These are sequence of inflations and or spontaneous breaths. The CMV, IMV, or CSV with a particular control variable, whether it's volume or pressure, for the ventilator inflations. There are 2 control variables and 3 breath sequences, totaling into 5 basic ventilatory patterns. Number 1, the VC-CMV, known as the VCAC. Number 2, the VC-IMV. Number 3, the PC-CMV, commonly known as PCAC. Number 4, the PCIMV. And number 5, the PCCSV. Number 7, breath or inflation sequences is a particular pattern of spontaneous breaths and or mandatory inflations. The 3 possible sequences are continuous mandatory ventilation, intermittent mandatory ventilation, and continuous spontaneous ventilation. Number 6. Okay. Spontaneous versus mandatory breaths. A spontaneous breath is made by the patient. It may or may not be assisted by the ventilator, and it can be both triggered and cycled by the patient. And then mandatory breaths or inflation is triggered either by the baby or by the ventilator. And it may be mandatory or again triggered by the baby and may be cycled by the ventilator or the baby. Number 5, machine versus patient trigger and cycle events. Trigger and cycle events can be either patient or ventilator initiated. Inflation can be patient triggered or patient cycled by a signal representing inspiratory effort, such as the electrical signal derived from diaphragm activity as with neurally adjusted ventilatory assist or the NAVA. So examples are patient triggering, ventilator triggering, patient cycling, or ventilator cycling. Patient triggering is where the patient prompts the ventilator to deliver the inflation. Ventilator triggering originates from the machine using a time signal. Patient cycling means ending the inflation based on the signals representing the patient-determined components. And ventilator cycling means ending inflation independent of signals representing the patient-determined components. Number 4, trigger and cycle events are classifications of inflation that trigger or start and cycle or stop an inflation. Trigger cycles are preset inflation frequency or the period between inflations equal to 1 over F. And trigger cycles are also preset apnea interval or various indicators of inspiratory effort, such as changes in baseline pressure or flow or electrical signals derived from diaphragm movement. The cycle variable are preset inflation time or time cycled ventilation, or it could also be pressure cycle, such as the peak airway pressure. Another volume cycle are those of that use percentage of peak inflation flow, and those that have electrical signals derived from diaphragmatic movement. Number 3, assistance with volume or pressure control. A ventilator assists breathing using either pressure control or volume control. The term control variable refers to the function that is controlled during a ventilator cycle, such as the volume control, the pressure control, and the time control. Number 2, assisted breaths. Ventilator function that consists of some or the entire breath cycle. This just means that the ventilator increases airway pressure above the baseline during inspiration to assist the breath. And last on our countdown, number 1, is the ventilator cycle, which is defined as one cycle of positive flow or inflation and negative flow or expiration defined in terms of the flow time curve. So as we know, ventilators give inflations and not breaths. So these are just an example of assistance with volume or pressure control. So when do we start mechanical ventilation? When there's inadequate or absent respiratory effort, when there's excessive work of breathing, high oxygen requirement, severe respiratory acidosis, moderate or severe respiratory distress, and contraindications for non-invasive support, and during the postoperative period. Some clinical guidelines, including the blood gas parameters, will be talked about in details in the next slides. What do we assess after starting mechanical ventilation? We want to observe for color and activity, patient-ventilator interaction, triggering, autocycling. We want to see adequate chest rise and diaphragmatic excursion. We want to know the work of breathing, the respiratory rate. Is there adequate circulation? Is there gastric distension? We want to listen to breath sounds on all lung areas. Is there adequate air entry? Is the chest rise symmetrical? Do we hear any adventitious breath sounds? How does the large airway sound? Is there an ETT leak? Does it sound like there's an obstruction from the carina? And how's the heart sounds? We also monitor the machine. A good eye should be able to distinguish if there's an abnormality on the waveforms being shown on the screen. We want to know the exhaled tidal volume of mechanical inflations. We want to see if there's a spontaneous breath coming from the baby. We want to measure the PIP. Is it working? How much is the percentage of leak, if there's any? On the flow time curve, is there evidence of sufficient I time and E time? Is there an excessive inspiratory hold? Is there an evidence of triggering and autocycling? As we talk about ventilator graphics in the next couple of slides, we will expand on the details of these things more extensively. This is just a sample graphical representation of monitoring the loops that we see on the ventilator screens. On the very far left, we can see the loop, and it's showing variation in tidal volume in a patient on IMV due to asynchrony. The middle loops shows reduced variation in tidal volume as the patient was changed to SIMV mode. And on the right, it shows the same patient as the patient was changed to assist control, and the loops are now showing synchrony. Guidelines for a lung protective approach. The universal goal during mechanical ventilation is to provide the most efficient mode of oxygenation with the least harm to the neonatal lung, while sustaining cardiovascular function and preventing neurologic outcomes. The basic principle of ventilator strategies involve an excellent nursing and respiratory care. And we also use non-invasive strategies first and intubate only when necessary. We use ventilation settings with the least damage to the lungs, and we can provide adequate but not excessive gas exchange. We minimize mechanical ventilation days, and we attempt to intubate as early as possible. We also carefully monitor physiologic status and gas exchange based on the disease pathophysiology and responses to changes in therapy. After the first few days, when the risk of IVH is lower, we can employ permissive hypercapnia as long as the pH is more than 7.2 and the PaCO2 is not too high, generally below 60 millimeters of mercury during the first week and below 70 in the second week or succeeding days. There is no evidence to support the routine use of sedation. Therefore, infants should be allowed to breathe spontaneously. Muscle relaxation is rarely indicated in the era of effective synchronized ventilation. Evidence showed that morphine relieves pain in the ventilated infants, but it may also increase the risk of adverse neurologic outcomes and prolongs the duration of ventilation. We have to reevaluate when an infant is fighting the ventilator, and we have to assess for signs of inadequate support in the presence of unacceptable blood gas. Sedation will only mask the clinical signs of inadequate support. The infant is in fact struggling to breathe and the blood gas is not bad because the infant is fighting the ventilator. The infant is fighting the ventilator because the blood gas is bad. Finding the optimal level of support along with physical means of comfort will allow most infants to settle down without pharmacotherapy. Routine suctioning should be avoided as well, as it leads to derecruitment, transient hypoxemia, and perturbation of cerebral hemodynamics. When secretions are detected and suctioning is needed, and we see it by auscultation or by perturbation of the flow waveform, rapid gentle suctioning without instillation of normal saline solution should be performed. Ventilator management of RDS. So the indications for mechanical ventilation include the following criteria. Respiratory distress with tachypnea with respiratory rate in excess of 60 to 70 per minute, or severe retractions involving the intercostal, subcostal, or suprasternal area. Inadequate oxygenation with SATs below 90s under the CPAP or oxyhood with FiO2 greater than 40 to 70%. Apnea unresponsive to medical management such as CPAP and methylxanthines using aminophylline or caffeine. On the blood gas criteria, if there's severe hypercapnia with PaCO2 of greater than 55 to 60 and arterial pH below 7.2, and severe hypoxemia with PaO2 below 40 and FiO2 greater than 40 to 70%. The settings and strategy have to be individualized based upon the severity of lung disease, the magnitude of spontaneous ventilation, and other variables, such as the clinical course and the presence of air leaks. The presence of retractions per se is generally not sufficient as an indicator of the need for mechanical ventilation. RDS, due to surfactant deficiency and inactivation, is relatively common in preterm infants, which leads to microatelectasis of alveoli and a reduction in lung compliance and lower lung volume. The reduced lung compliance is associated with very short time constants, which is 0.05 to 0.1 second. So attempts to expand atelectatic areas of the lung using higher peak pressures may result in volutrauma to both airways and distal lung parenchyma. Respiratory support of preterm infants with RDS usually consists of escalation from either supplemental O2 with pressure at first using the oxyhood or oxygen environment or CPAP before going to mechanical ventilation. The initial settings for conventional pressure-limited or time-cycled ventilation for neonates are the following. We use respiratory rate of 50 to 70 breaths per minute with PIP enough to activate chest inspiratory excursions, usually 10 to 20 cm of water. We use moderate PEEP of 4 to 5 cm of water. The inspiratory time usually ranges from 0.25 to 0.4 seconds, with the FiO2 from 0.4 to 0.7 depending upon the FiO2 on the CPAP at the time of transitions. The settings are not dependent upon factors such as the birth weight or gestational age or postnatal age of the infant, but upon lung physiology and also upon the gas exchange and lung mechanics. The blood gas targets for the initial phase of RDS are usually a pH of 7.25 to 7.3, PaO2 of 50 to 70, with SATs 91 to 95 and PaCO2 of 45 to 55 millimeters of mercury. Following administration of surfactant, pulmonary mechanics may change rapidly. Ventilator settings need adjustments frequently, and your clinician will be expected to change these settings based on the following. As you monitor the baby's chest excursion, the change in O2 sats, the transcutaneous O2 or CO2 measurements, the end-tidal CO2, and blood gas measurements. Starting the ventilator settings using rapid rates and shorter I times support the short time constants of the neonates and reduce air leaks. So you will notice and you can anticipate that the first things that the clinician will change are the rates. If the infant has lower PaCO2, she will increase the ventilator rate rather than increase the PIP. This is to reduce volutrauma. So in situations where the infant has a low PaCO2, she will reduce the PIP first to the lowest required pressure for adequate chest movement and then decrease the rate next. For the management of refractory apnea of prematurity, ventilation using lower pressures are expected, and we also use low rates and low FiO2 to keep SATs 91 to 95%. These are used for preterm infants, especially the extremely preterm, and those with CNS injury, those that have severe apneic episodes, those that are unresponsive to CPAP and methylxanthines, and those that failed a trial of NIPB. As such, infants being ventilated primarily for apnea have relatively less lung disease. Ventilator management of infants with BPD. For babies with BPD, it should be an individualized approach due to the varying injury and remodeling of the lung parenchyma and vasculature and airways. Faster rates and lower pressures work best for infants with homogeneous disease, and lower rates with higher PIP and longer I time due to longer time constants will work best for neonates with patchy atelectasis and areas of hyperinflation. Permissive higher PaCO2 is also used with pH below or higher than 7.2. They also have better VQ matching with higher levels of PEEP, and they require very high peak pressures and high tidal volumes despite relatively lower rates to maintain oxygenation due to severe VQ mismatch. The default technique is not recommended for these babies because the increased setting during deterioration while slow weaning aggravates ventilator-induced lung injury. Babies with BPD needs to be screened regularly for PPHN. So infants diagnosed with pulmonary hypertension in the setting of BPD may need additional specialized investigation. CT angiography, cardiac catheterization, or transesophageal echocardiography may support this goal in order to start appropriate therapy and intervention, including inhaled nitric oxide, sildenafil, or higher oxygen saturation targets. Your clinician might also consider tracheostomy for prolonged mechanical ventilation. This will also ensure airway maintenance, assisting the pulmonary toilet, and reducing dead space. Or for the use of neurally adjusted ventilatory assist or NAVA to synchronize with patients' respiratory efforts. The conditions arising from the extrapulmonary shunt affects pulmonary vascular resistance, inducing severe hypoxemia and respiratory acidosis, further leading to the PPHN. Initially, starting oxygen by oxyhood or CPAP is needed to prevent that hypoxemia. But if hypoxemia is persistent, mechanical ventilation will be ordered by your clinician. Persistent hypoxemia is reflected by the following: SATs of below 90, PaO2 of below 50, or respiratory acidosis with a pH below 7.2 and PaCO2 of greater than 55. The mechanical ventilation settings are started at faster rates of 50 to 70 per minute with shorter inspiratory times of around 0.3 to 0.4 seconds to help reduce PaCO2 and prevent respiratory acidosis. The early initiation of inhaled nitric oxide is recommended. We know that inhaled nitric oxide induces pulmonary vasodilation. It also improves VQ matching. In the events where the oxygenation index is between 15 to 20, we want to start inhaled nitric oxide rather than choosing to increase ventilatory pressures and rates. This is because the use of very high ventilator pressures or rates in the setting of PPHN may lead to excessive mean airway pressure, and it could further reduce pulmonary circulation. Ventilator management of infants with congenital diaphragmatic hernia. In collaboration with pediatric surgeons, most centers now use a strategy of gentle ventilation with initial cardiopulmonary stabilization followed by delayed surgical repair, sometimes while on ECMO. The initial settings used are rapid rates, adequate PEEP for tidal volume delivery and chest movement, short inspiratory times of around 0.25 to 0.35 seconds, FiO2 as needed to maintain adequate oxygenation, sometimes greater than 70% FiO2, with the general goal of maintaining sufficient preductal oxygenation. The preductal SATs are 90% preferably, or at least 85%, while tolerating higher PaCO2 of 60 to 65 and a pH of 7.25 or greater. According to Andrade and colleagues, neurally adjusted ventilatory assist is a minimally invasive technology that releases proportional pressure cycling in response to the electrical activity of the diaphragm. Therefore, it adapts to the ventilatory needs of the patients according to its demands. There are benefits to the NAVA, and it's as follows. Current studies indicate that neural ventilation in infants and children is better tolerated compared to conventional ventilatory modes. It appears to be safe, it has better patient-ventilator interaction, it provides comfort, it requires a lower level of sedation, and shortens the length of stay and offers monitoring of electrical activity. However, its long-term role is still uncertain, especially regarding the duration of mechanical ventilation, the length of stay, and mortality in children. High-frequency ventilation. There are three general types of HFV used in the neonates: the high-frequency oscillatory ventilation, the high-frequency jet ventilation, the high-frequency flow interruption. The indications in using HFV are PPHN with or without meconium aspiration or other lung disease, post-surgical support for infants with gastroschisis, omphalocele, and necrotizing enterocolitis, and other similar problems that may benefit from HFV, in the face of lung disease and increased intra-abdominal pressures. High-frequency oscillatory ventilation. HFOV is produced by an electromagnetic piston device that moves air back and forth at the airway opening and produces limited bulk gas flow. A decrease in frequency or increase in tidal volume by way of an increase in set amplitude increases carbon dioxide removal. In using the SensorMedics 3100A, you can anticipate that your clinician will start at a setting of 10 to 12 Hz. This is equivalent to 600 to 720 oscillations or cycles because 1 Hz is equivalent to 60 breaths per minute. If your clinician notices on the blood gas that your baby is retaining CO2 or is very acidotic, she will order a decrease in the frequency. If on the blood gas your baby has a very low CO2 level, she will order an increase on the frequency so that the baby can retain CO2 and maintain an acceptable level. On the mean airway pressure, we start at a setting of 20 to 25 cms of water. Starting a 2 cm increase than the baby's current conventional settings is usually the normal setting on the HFOV. Your clinician will also perform an escalating recruitment maneuver, which is an increase in the settings until an acceptable saturation is reached. On the amplitude, we start at 20 to 25 cms of water, and it is increased in increments of 3 to 5 until an acceptable wiggle is noticed. The inspiratory time can be set from 30 to 50% of the total cycle. As per protocol, we check the blood gas after an hour of initiating ventilation. And also, we monitor the baby for 2 hours if the baby is improving in this mode of ventilation. The high-frequency jet ventilation. The HFJV delivers a high-velocity jet of gas directly into the airway and have passive exhalation. Using a microprocessor-controlled, pressure-limited, time-cycled ventilator servo controls. CO2 removal is achieved using lower peak and map, and the I time is normally kept at the shortest value. Thus, the IE ratio decreases as frequency goes down, therefore the tidal volume remains the same. The Bunnell jet ventilator is started on settings of 240 to 600 cycles, or an equivalent of 4 to 10 Hz. Most commonly, our neonatal population is started at 240 to 420 cycles, less than those typically used in the HFOV. The pressure ranges from 8 to 50, and the I time is started at 0.02 to 0.034 seconds. An open ventilator patient circuit is essential because HFJV is used in combination with a CMV to provide PEEP and occasional sigh breaths. Why is it necessary to recognize ventilator graphics? Ventilator waveforms enable us to identify pathophysiologic processes. It helps us recognize patients' response to therapy and monitor patients' disease status. It helps us calculate respiratory mechanics, and it optimizes ventilator settings and treatment. It enables us to determine the effectiveness of ventilator settings and detect adverse effects of mechanical ventilation. It minimizes the risk of ventilator-induced complications. and allows us to interpret, evaluate, and troubleshoot patient problems or responses to the ventilator. The basic waveforms we see on the ventilator screens. These are graphical representation of what the ventilator delivers on the baby. On that first wave, it shows the volume being delivered at a given time. The second wave depicts the flow of air coming in and out of the baby's lungs. And the third depicts the pressure being delivered to the baby. And so these basic waveforms with the variables are plotted against time. The loops are two-dimensional graphic display of two scalars. The first loop is the pressure versus volume loop, while the second loop depicts the flow versus volume. Pulmonary mechanics and loops. Changes on the pressure-volume loop should be recognized as early as possible. One of these changes, such as excessive beaking on the loops, will signal that there is excessive pressure being given to the neonate. It can show changes in mechanical properties of the lungs, such as air leaks, evidence of overdistension, adequacy of applied PEEP, and circuit problems. So, once you recognize this early, it is necessary to change settings to avoid overdistension or pneumothorax. Patient triggering on the pressure-volume loop. Efforts by the patient while on the ventilator may show triggering on the pressure-volume loop, showing dyssynchrony on the lower left quadrant. This area can be increased or decreased based on adjusting trigger sensitivity on the ventilator. Increased resistance on the pressure versus volume loop. As airway resistance increases, the loop becomes wider. Increased bowing of the pressure versus volume loop should alert the clinician to investigate whether the endotracheal tube is kinked or obstructed, whether suctioning is needed, or bronchodilator administration is necessary for airway narrowing. Compliance changes. The shape and position of the pressure-volume loop can be altered by change in compliance. Decrease in compliance will cause the pressure versus volume loop to rotate towards the x-axis, as represented by the lower loop on the graph. This indicates the need for greater pressure so that adequate oxygenation and adequate volume can be given to the baby. The middle loop is represented by the normal parameter, while the upper loop is represented by increased pressure being given to the baby, needing a reduction so that we can avoid overdistension or pneumothorax. Zones of barotrauma and atelectotrauma on the pressure-volume loop. It is also an example of the beaking, which shows that alveolar distension is excessive. Pulmonary compliance decreases at this upper inflection point, meaning this is a signal to lower PIP to prevent polytrauma. Air hunger on the pressure versus volume loop. The pressure versus volume loop may assume the shape of a figure 8. This unstable loop formation indicates instability of the chest wall. It is a situation where the infant creates negative pressure in response to air hunger as the baby inhales, resulting from inadequate hysteresis. So this can be corrected by increasing flow or rise time. Flow volume loop describes the airflow during tidal breathing. Volume is shown on the x-axis and flow is shown on the y-axis. The flow-volume loops are particularly important in the assessment of excessive airway resistance and in alerting for the presence of copious airway secretions, circuit leaks, or obstructive lung disease. Turbulence in the flow volume loop displays a sawtooth appearance. This means that the circuit airway flow is set too high, or if there are secretions in the airway, sensor, or circuit that interferes with the flow. This can be seen on both inspiratory and expiratory components of the flow volume loop as having waveform with serrated edges. Careful inspection for secretions or condensation, as well as consideration for endotracheal tube suctioning, should be undertaken when the loop produces such. Premature cycling on flow waveform. This is when the patient initiates active expiratory efforts while the ventilator is continuing to deliver inspiratory flow. Pressure spike on the pressure waveform during middle to late inspiration can be seen. On the flow waveform, it is seen as an abrupt decline in inspiratory flow near the end of inspiration. It can be fixed by reducing inspiratory time or tidal volume. This is just a sample troubleshooting guide. For example, when there's air trapping or the machine is causing an auto peep, the causes could be thick secretions or bronchospasm, or there could be insufficient expiratory time. There could be an early collapse of unstable alveoli or airways during exhalation. How to identify these things on the graphics? So you look on the pressure versus time wave line. While performing an expiratory hold, the waveform rises above the baseline because, of course, it looks like there's an obstruction. On the flow versus time wave line, the expiratory flow does not return to the baseline before the next breath begins. Or on the volume versus time wave line, the expiratory portion does not return to the baseline either. On the flow versus volume loop, the loop does not meet at the baseline. And on the pressure versus volume loop, the loop does not meet at the baseline. So how to fix it? Identify the cause and resolve. Of course, this is also with the help of the RT. And then give a treatment or suction. Decrease inspiratory time. But before you do that, of course, you have to check the baby from head to toe. You do a blood gas, and that will help your clinician to decide if there's a need to decrease the eye time, increase the flow, or add PEEP. In summary, using the knowledge gained in understanding the basic parameters of conventional ventilation will enable you to optimize ventilator settings and treatment. And as you use the evidence-based concepts, it will help you establish and promote the universal goal on protecting the lung architecture, using the least harmful mode of mechanical ventilation to maintain hemodynamics and prevent neurological outcomes on your patients. Anticipating the need of the baby and using the clinical and blood gas criteria indicating the need for mechanical ventilation will enable you to provide prompt and appropriate treatment. And it also works the other way as you start to wean and prepare the baby for extubation. The most important factor in the protective lung approach is you. Your excellent nursing care and respiratory care will help develop those core parameters of protecting the baby's lungs. You have to reevaluate when an infant is fighting the ventilator and rethink if sedation is masking inadequate ventilatory support. Finding the optimal level of support along with other physical means of comfort, including your developmental care strategies, will allow most infants to settle down without pharmacotherapy. And recognizing ventilator graphics to detect adverse effects of treatment and preventing the risk of ventilator-induced complications will prepare your baby for early extubation, decreasing their length of stay with improved neurological outcomes. So thank you for listening to this presentation and have a great summer.